you might check to make sure.
See, look at how crooked we are.
Well, first we're going to change it so Echo reads.
Oh,
We're
yeah,
going to
that's
zoom
big.
in.
It doesn't look that crooked, but when you actually see the ceiling,
The sign is not straight with the ceiling.
the sign is
Is it?
straight to the
Is it?
ceiling.
Okay.
But if you look at it,
Yeah.
when she scrolls on the ceiling, you can see like the
Right.
crooked.
Yeah.
Weird.
Is that good enough? Hi. Hi, Kimberly. We're going to get started in about 10 minutes.
I'm so hungry.
Right, and the point that when I had, yeah, so do I. Hi, Chad. I'm just gonna make Chad is speaking. Put stuff on mute there, Chad.
Oh, I gotta mute me. What the? You're mine's off.
Okay, mine.
Hello?
I said,
Okay. I didn't get the chat.
Okay, everyone
There's people in the same room or close to each other.
who are in the same room together, when you are together, you need to only have one sound on one computer turned on. If you have several computers in one room and you have the sound turned on all the computers, we won't be able to hear each other. We'll get lots of feedback.
Or devices.
So, or devices, computers or devices. So everyone's muted as we come in, but please be sure to make sure that if you're in the same room with people who also have computers and devices, that you've all turned your sound down except one person. Okay, hopefully that helps. We're gonna get started in about 5 minutes. Well, welcome everyone. We're so glad to have you here on this cold Minnesota day. My name's Rebecca Buller, and you have joined the Wayside Women's Services Echo. And today we're excited. Tell me, can anyone else hear the construction going on in the suite next door? You can. We're going to have to speak with a strong voice. It wasn't happening until, of course, I said hello, and then the noise started. If it gets to be too difficult, will someone please chat and let us know what's happening as far as your ability to hear the echo session? Again, now my name is Rebecca Buller. I work at Wayside Recovery Center. I'm the education and prevention manager here, and my primary job is to conduct these echoes and find wonderful speakers like Randy to come and share with us. We're going to start today by having folks do a quick introduction. Let's start with the folks in the room here. Sherry, do you want to start?
Yes, I'm Sherry with Wayside.
I'm Angela with Wayside. And I'm not sure if you could hear that, but that's Angela with Wayside here in the room. And then let's go up to Eric with no photo, but Eric, can you unmute? And I'm going to unmute you, and would you please, oh, you did. Please introduce yourself.
I'm Eric. I'm with the Public Defender's Office.
Great, welcome Eric. And let's go to James Coombs. I'm going to close the door. Okay.
He didn't unmute himself.
James, we can hear you now. Would you please introduce yourself?
Yep, James Coombs of Right Time Sober Living.
Welcome.
Thank you.
And now, Rick, would you like to introduce yourself, please?
Yes, hi, I'm Rick Kutcher, and I am Recovery Navigator at the Minnesota Association of Sober Homes, offering peer recovery support services.
Welcome. Stephanie, would you like to introduce yourself?
Oh no, it's unmuted. I'm Stephanie. I'm with Right Time Sober Living.
Wonderful. Is it Taryn Curtis? Oh, we can't hear you, Taryn.
Can you hear me now?
Yes, thank you.
All right, I'm Taryn. I'm a recovery navigator with New A3Rs.
Welcome. Charles, can you introduce yourself, please?
I'm Charles Erickson with Right Time Sober Living.
Okay, thank you.
That's the right time.
And Chad, could you introduce yourself, please?
Yes, I'm Chad with Right Time Sober Living as well.
Wonderful. So glad you're here.
Thank you.
And we have Rick Moldenauer. He doesn't have a mic, but he has logged in through the chat, and he's at DHS. Jennifer, could you introduce yourself, please?
Jennifer with Right Time Sober Living.
Welcome. Krista, could you introduce yourself, please?
Hi, I'm a nurse at AICDC Withdrawal Management / Detox.
Welcome. Let's see. So Mark, could you introduce yourself, please?
Yes, my name is Mark, and I'm with Right Time Sober Living as well.
Welcome. So we did. Alyssa, could you introduce yourself, please?
Hi, I'm Alyssa. Yeah, I'm Alyssa with JCS Effective Sober Living.
Welcome. We did Krista. Kimberly, could we hear? Whoa, Kimberly moved when I touched her. Okay, there we go. Kimberly, introduce yourself, please. Okay, Kimberly, we don't have sound for you. Oh,
She didn't join with her audio.
you can join with the audio with the person next to you.
There she is.
Yeah, just do that.
Oh, Kimberly, right time, sober living.
Hi.
Hi.
Go ahead.
I think she's done. She turned her audio off so she wouldn't get feedback.
Okay. Good Lord.
There's a lot of this.
Angie, could you introduce yourself, please? Angie? All right. We also have Lucia with us, who's usually here in the office, but she's out working at Mankato State this morning or this afternoon. Let's go to Brian. Brian,
Hi, I'm Brian. I'm with Recovery Road Homes.
welcome. And Ashley. Ashley? Looks like Ashley Herget. It looks like, and you're with Minnesota Recovery Connection, is that right?
Yeah, with the mobile suds team.
Wonderful. So glad you're here. And then Samantha, could you, I'm unmuting you, please introduce yourself. Sam? Sam may not have a mic. Samantha is with Wayside. And Ryan. Can you go ahead and introduce yourself, Ryan? I think that Ryan may also not have a microphone. She is with Wayside. And then we have someone at a 763 phone number. Can you either, I'm going to unmute you if you'd like to tell us who you are. All right. Let's hopefully you can type something in the chat and let us know. Did I miss anyone? Wonderful. Okay, so I'm going to turn things over to Randy very shortly. We're so glad you're all here. And how are we doing on sound? Can you guys hear us over the construction? Am I getting a yes? How about a nod or wave at me? Okay, great. Thank you, Rick. All right, so let's turn things over to Randy and then we will pull up your PowerPoint. Do you want that now? Or?
Sure.
Okay.
Hi, everyone. I do know several of you on the phone. My name is Randy Anderson. I'm a person living in long-term recovery. And what that means to me is I haven't had to use any alcohol or drugs or mood-altering substance since January 9th, 2005. And because of my recovery, I've been able to do really a lot, just unbelievable things. I think one of the coolest things, and unfortunately we need it though, is I'm able to provide this training to our state. I've been doing it now for almost 6 years. I was trying to figure out the other day, like how many of these I've done. I think I've done around 1,000 of these trainings. I've trained somewhere in the neighborhood of 10,000 people and distributed over 20,000 Naloxone kits in 6 years. I've touched all 87 counties of our state, which is really cool. And it's just one of those gifts of recovery. But I also own a home. I vote. I pay taxes. I'm a responsible pet owner. I have healthy relationships, like all those things that like normal people do. But that's all because of my recovery. My involvement with the Steve Rummer Hope Network started in 2014 when I was convinced that college might be a good idea for me. I never really thought it was. I would say the second scariest day of my life was driving to college. The first was driving to prison. I just thought at age 43 with a GED that I received while I was incarcerated, I just didn't think college was a thing for me. And I was wrong. Thank God. God put people in my life that believed in me more than myself, again, as usual. And I've completed, I have Associates of Science degree in Addiction Counseling from MCTC or Minneapolis College, Bachelor of Arts on Human Services from Bethel University, and I'm a state licensed alcohol and drug counselor. And I just never thought any of those things would be a possibility in my life. I was sitting in my first classroom to become a counselor, and this amazing woman came in and spoke. Her name is Lexi Reed Holtum. She was the executive director of the Steve Rummer Hope Network, and she was also Steve's fiance at the time of his death. So she told this story, somewhat of a little bit of what I'll talk about today, but I was really blown away. I didn't know our country was in the middle of an opioid epidemic. I was shocked, like, how did I not know about this? At that time, there were 91 people dying every day in our country from opioid overdose. And I thought, why isn't this on the front page of every newspaper? Why doesn't this lead every news story? Unfortunately, we're a lot higher than that now. We're close to 130 just from opioids every day. So the problem has gotten worse, although in Minnesota, which I'll touch on a little bit here, we are improving. It's nothing to cheer about. We have a lot of work to do, but we are getting better in our state. So Steve Rumler was prescribed opioids for a back injury. It came to a point in his life where he could no longer get those, there we go. Perfect. Where he could no longer get those pain pills, and he met someone and they said, just get heroin. It's the same thing. The family believes it was the first time he'd ever used heroin. He overdosed and died. 2 weeks after his death, Steve's parents, Judy and Bill Rumler, and his fiancee Lexi, started the Steve Rumler Hope Network. And even when I talked to Judy today, who's one of my dearest friends, she'll say, I just asked her, boy, it seems like a lot of work you've done, Judy. And she goes, I wanted to do something to honor my son, of course. But for her, the bigger impact or message or what we're trying to do here is if we can save one family from going through the same pain that her family went through, that's the mission, that's the goal. I know for a fact they've done that thousands of times over because of their work here. So Steve used heroin, he overdosed and died. So it's a little, I'm sorry, this is an altered version. This training is usually an hour and a half long, so I had to cut it down for today, and I haven't done this version in a while. This is the version actually Rick Moldenhauer will probably recognize. I did for the Department of Human Services a couple years ago when we had our Save a Life training where I did 6 trainings in 6 hours. This is that version. So, oops, I gotta not push the buttons. There we go. Scroll. Okay, so as I hope most of you know by now, the leading cause of accidental overdose or of accidental death in our country is overdoses. So the new numbers, so when I say new, the newest data we have is 2018. We're always about a year behind. It takes a long time to compile all the data and get everything together. So according to the CDC in 2018, there were 67,367 lethal drug overdoses. That is about 185 people per day. Opioids were the cause of 69% of those. About 14,996 from heroin, 31,335 were from prescription opioids or synthetic opioids. So if we look at that in 2018, fatal overdoses just involving opioids was just a hair under 47,000, which actually is still more than car accidents every year in our country. So that's just opioids, which still kills more people every year than car accidents. So if we do even more math, that means that's one person every 13 minutes that's dying in our country or now. So we're now at about 127 a day just from opioids. And there's a lot of talk about this too, that there's a lot of underreporting going on. The CDC has said at one point that these numbers are 20 to 35% underreported, only because of, well, some of the stigma around the disease of addiction. Little towns with close relations to their coroner's office or their medical examiners has falsified, we've been reports they falsified death certificates. They didn't want the community to know that their loved one had died from a drug overdose, and so they just put cardiac arrest on the death certificate. Autopsies and tox screenings for opioids are very expensive, and a lot of times that doesn't get done. So again, we know that these numbers, they're as accurate as they can be with the information collected. But that still means since the year 2000, more than 500,000 Americans have lost their lives to overdoses. So Minnesota, I always say we're doing better than most of the rest of the country. You don't want to live in Ohio today. They lose around 4,000 people a year. People make fun of Minnesota. They say we're too cold, too liberal, and are too high at taxes. I think some of those reasons, or maybe all those reasons, are why our death numbers are lower. We rank about 40th in the country currently. So up until last year, or 2018, we had been climbing the hill. So we had relief in 2018 for the first time in nearly 2 decades. We're now going down the hill, and we hope that continues. We actually have seen some of the highest percentage decreases in our state than some of the nation. I have a friend who lives in Greenville County, South Carolina, and they saw an 80% increase in overdose deaths. So there's not everyone is seeing the successes we're having in Minnesota. Again, I don't want people to cheer and think that this is over and we've solved the problem, because we haven't. Just because they're going down doesn't mean there still aren't a lot of people dying every day. So with the numbers we now have, we know that overdose deaths in Minnesota decreased by 13.53% from 17 to 18. So that from in 2017, there were 733. In 2018, there were 636. So that, of those 636, 331 were opioid-related deaths. Now, these were still the preliminary numbers from Minnesota Department of Health. I reached out to them 2 weeks ago, and they still said they haven't really finished numbers yet, which is a little surprising to me since they're talking about 2018. However, they said that I could use the preliminary numbers, and those are fairly accurate. So that's what I'm going with. So we do know, though, in 2017, more than half of those deaths, or excuse me, I forgot to change the date there. 2018, more than half of those deaths were related to prescription or synthetic opioids. So again, according to the preliminary numbers, 2018, 134 from prescription opioids, 184 from synthetic opioids, 85 from heroin. And then our numbers for other drugs, so psychostimulants like meth is 161, which is on the rise. Benzodiazepines like Valium, 65. Cocaine, 51. All categories were rising until last year, and now we've seen a decline in some. One thing I like to talk about quickly here is when we talk about cocaine deaths. So year to year, actual cocaine overdose deaths don't change a whole lot, but the media, God bless them, but they do some sensationalizing or fear-mongering, and so we see the headlines read cocaine deaths surpassing opioid deaths. So that's not accurate. Not completely accurate. What's happening is all of our street drug supplies are now tainted or adulterated. So you must assume that any drug that you get from the street, off the internet illegally, or from an unknown source is probably or most likely laced, or we say adulterated with fentanyl. And because the deaths we're seeing mostly, like this last summer or fall when you saw the South St. Paul rash, they had 6 people overdose in one house. Those were all people using cocaine. And the cocaine was laced with fentanyl. And so we're seeing a huge spike in these overdose deaths because all of our drugs are now not what people think they're getting. Although we do have still, and I always like to mention, we do have a huge meth problem regardless, that we don't talk about enough, because you don't die as quickly from meth as you do from opioids, unless it's tainted with fentanyl, of course, then you do. So the Steve Romer Hope Network designed 3 programs to help combat the problem here in Minnesota. So the first one is called the Addiction Lecture Series. Forgot the exact name. Prescriber Education Program. So they work with the Minnesota Medical Association, and the University of Minnesota allows them to use their facility, and they bring in doctors that are educated on responsible prescribing of opioids or not prescribing opioids. And they videotape those lectures and they upload those to the MMA website. So if you're a prescriber and you need your CEs, continuing education credits, you can go online and you get those for free for watching these lectures. They do about 6 to 8 of these per year. It's interesting though, I always find it when I do these trainings, I ask people, now of course, I'm just gonna ask it virtually, like, does anyone know what Rotary clubs do? And the general answer I get is, I have no idea what Rotary clubs do. And so I know they do a few things from my years of doing this training and talking to people. Is they helped cure polio. So they actually fundraised millions of dollars to help us find a cure for polio. They actually still provide eyeglasses to underserved communities. So if they have vouchers, they fund that program. They actually are helping fund this program. They are one of the main funders for the prescriber education program, because they realize that this problem was also caused by doctors. And we have a whole group of medical professionals and it's not I'm not here to blame them. They were trained incorrectly. They were lied to in medical school. They weren't given the correct information. So now we have a lot of work to do though to undo that. And so this is a program aimed at helping to do that. So it's a really cool program. Doctors are going to be a huge role in undoing the mess we have now. So the advocacy is another huge part of the Steve Romer Hope Network. So usually I ask how many people have heard of Steve's Law. And I would tell you, even 2 weeks ago when I did a training, still only 25% of the hands in the room went up. And that means that I still have a lot of work to do, or we have a lot of work to do. I always say, though, I created a new state system. So I thought, when I joined the Steve Romer Hope Network in 2014 as a volunteer, just fresh in college at 43 years of age or 44 years of age, I said, wow, this is really cool, this organization. They wrote a bill. I mean, they got it through our entire state legislation, signed into law by the governor. Like, that's Now that I work a lot in advocacy and politics, I know how impossible that can be sometimes. Last year, there were 2,950 bills introduced into the legislation, and very few of those actually got signed by the governor into law. So it's a feat to get that done. So I started asking questions, though. So when the state passes a new law, how do the people find out about it, right? And then I even said something, I did get a little chuckle out of the group I was with. I said, well, I just assumed the state had a system where they had all of our email addresses, right? And when a new law got passed, we would receive an email from the state saying, hey, here's the new law you should know about. Well, ironically enough, there is no state system there. And that kind of still blows me away. Like, there's no state system to disseminate that information to the people. So how do we know when a new law gets passed? We don't, unless we do our own homework. So we found out really early on that we were the state system. And again, I've been traveling around the state for 6 years now, trained tens of thousands of people, and I still walk into rooms every day where sometimes no hands go up, and it's very discouraging. However, what I'm going to challenge all of you to do, even those virtually, is I want you to talk to people about Steve's Law. After today, I want you to tell them about Steve's Law. I want you to tell them about Naloxone. And I would say I challenge you to talk to at least 3 people. So next time I come back and do a training like this, maybe half the people will know, maybe a year after that, 3/4, maybe 3 years, all the people. Because it's going to take years before the entire state actually understands and knows what Steve's Law is. So the nuts and bolts of Steve's Law is, first of all, it allows all persons to carry Narcan or Naloxone, the medication to reverse an overdose. It allows you to carry that medication legally without a prescription. It also allows for third-party prescribing. That means you can simply go to your doctor and say, you know what, I want Naloxone, and he should write you a script. He's not mandated to, but we do. I've had many conversations with physicians over the years because they didn't know that they were allowed to write that prescription. Is there a question?
I'm just going to see where someone is.
Gotcha. And so, okay. So the third-party prescribing is important. Now, too, we're really fortunate that we have, there's such an awareness around this that you can literally walk into any pharmacy, at least for sure in the metro area and some outstate areas. You can just walk into a pharmacy and say, I want Naloxone, and they can give it to you. They'll run your insurance. If you have somewhat good coverage, you might pay a small copay. It might be, if you have really good insurance, you might walk out without paying any copay. It just depends on your insurance, the pharmacy, things like that. The other part that's really important, though, about Steve's Law is there's a part of it that's called where we provide a limited immunity. So for me, this is really important. As a formerly incarcerated person that was sentenced to 87 months in prison as a first-time nonviolent drug offender with no criminal history, I'm telling you, there's something I would have never done in that previous life. I would have never called the police. Even if it meant my friend was going to die, because I would be too afraid to get in trouble. I didn't want to violate my parole, or I didn't want to go back to prison, whatever. So I wouldn't call, right? So the beauty of Steve's Law is if I'm using with someone, we're using together and my friend overdoses, and I call 911 and use Naloxone to try to save his life, that my friend and myself are void of some prosecution. Now, it only covers the people, the overdosing individual and the person calling. I always say to the other, if there's a party going on or a room full of people, if you don't want law enforcement involvement, you should leave. Now, we haven't heard of any police yet. I haven't heard of any where they go to a party and they start arresting people. But I have my own interactions with the law enforcement over the years, and I have a level of distrust once in a while. And if you get a rookie cop fresh out of the academy and wants to, I want to arrest people, right? So be careful. So again, it only provides immunity for the person using and the person overdosing. And what that immunity looks like, it allows, so if you're on probation, parole, or supervised release, you cannot be violated by your supervising agent. It also provides a certain amount of drugs on scene that you're immune from catching. I would say catching a case like catching a cold. It's the lingo we use, and it's like I try to change it, and it's impossible. It's just ingrained in me. So what we talk about, so if you have less than a third-degree possession amount of drugs on scene, you cannot be charged with a new drug crime. And what a third-degree possession looks like in Minnesota is 3 grams of heroin, 10 grams of cocaine and meth, and we're decriminalizing marijuana, so the weights have gone up on marijuana, but it is 10 kilograms or 22 pounds of marijuana. I know I kind of laugh every time I even say that. I have no idea what 22 pounds of marijuana looks like. I kind of have this vision of my trunk being full, or you see the news where the people are carrying the big bales of marijuana.
Yeah.
Like that's kind of what I think 22 pounds looks like. I have no idea. Although I'm a firm believer as the vice president of the Minnesota Second Chance Coalition and a formerly incarcerated person that people don't belong in prisons or jails for drug use or possession. Like, right, they have a medical problem and it should be treated like a medical problem. Now, if you have a trunk full of heroin, you're trafficking, you need to go to prison, right? So there's a difference. So I'm okay with when people think that's a lot of marijuana. Like, I don't care. I don't want people incarcerated because they possess some drugs or you were using some drugs. So those are the nuts and bolts of Steve's Law. So now I consider all of you experts and you will help spread the word. So the other part of the program that's important is is part of this program is the overdose prevention program. And the Seaworm or Hope Network has a medical director that has a standing order that she's put her license and her insurance on the line. So I can do this. And so anyone really in the state can do this or distribute kits under her license and her insurance. It's not a lot of liability. Really, Steve's Law was a good law and it really does protect the physicians prescribing it as well. But organizations want to know that it's directed under a medical director. So it's more of a formality than anything, but it's important. It's an important formality. So the 5 areas that they wanted to partner with are so healthcare facilities or MAT clinics, detox centers. MAT stands for medication assisted treatment for those that don't know. The thing about that, so really cool now, a lot of the facilities we work with, especially emergency room departments, when a person goes in there after an overdose, and they're stabilized and then, released, they're usually provided a kit nowadays in a lot of the emergency room departments, which is really cool. And people say to me all the time, though, what good does that do, Randy? Because if you give someone a kit, they can't save their own life, and which is true. So, and I don't really care what you see on the news, and I'm not here to make fun of police officers. I work with them closely. I'm a community advisory board member for the sheriff's office. So but I see on the news where an officer thought he was overdosing and he gave himself a shot or a nasal blast of Narcan, right? So that's impossible. If you overdose, you don't know what happens. The symptoms are much different. If you actually look, it was probably an anxiety attack. It wasn't really an overdose. So I don't want people to think that they can save their own lives with their Narcan, because you can't. However, I've talked to many persons over the year that have been saved, and they said, I went to my friend's house, I found them overdosed, and there was a kit there. And they were able to use that kit to save their friend's life. So we just want to make sure. There were some recent studies done in New Orleans last year, or the year before last. So 87 to 90% of all overdose reversals are performed by community members. Yep, family members or loved ones, or friends using together. Only 10 to 13% are performed by first responders. So what does that tell me? It tells me that the kits should be in the community. Like, every person should carry a kit on them at all times. I mean, I probably have 10 or 12 on me at all times, but that's just because of what I do. So the other areas we like to partner with is treatment centers and sober living facilities. We have a 2-tiered program. The first tier is usually we go in and train the facility and the staff and make sure that the facility carries naloxone in their program. The second part of the program is we like to train the clients. So, and I've done this now. A few years ago, very few thought it was a good idea to train clients, because we had the belief that we're only enabling people by giving them, right? I mean, and let's hope most of us are past that stage now. If people are going to use, we're not going to stop them. We're not going to enable them just because they have an naloxone kit. I just want to be clear on that. It's not, I don't like those. Again, that's a lot of the media that has made us believe things like that. So the second tier is, we like to train the clients, like the people that live in those sober living houses, that go to those treatment centers, like train them and their family members. And so they all can carry a kit and save a loved one's life. The other ones are community naloxone trainings. Those are actually probably my favorite. I'm not gonna lie. So I get to go to like weird places like churches. I think my favorite one was if you drive down 35W South, there's a truck stop in Faribault, Minnesota called the Truckers Inn. Like, and some of you may be familiar with that. I remember as a kid stopping there with my parents, like, to eat. Well, they had me come down there to do a training, and they blocked off their dining room, a big section of their dining room. And I had a portable projector, and I blasted the screen on the wall, and I trained 44 people while they ate dinner. They were eating hot beef and hot turkey sandwiches, and they looked delicious. But I thought that was probably one of the strangest trainings I've ever done, right? I mean, I've trained as few as one person in the lobby of a bar to as many as 125 or 175 at a conference. So really, community trainings are really cool. That's, I think, where, again, from the numbers, we know that that's where the lives are being saved. First responders. So I worked with all the, EMT, EMS, police, fire. I've trained everyone, anyone, anywhere. I always kind of joke around though. My favorite audience to train though is law enforcement, only because I was once a patient in some of their facilities. So now when I stand in front of them and talk about life-saving naloxone, that I was once in their custody, and now I get to help them like save lives. So it's pretty cool. And then we also work with a lot of the treatment courts around the state. I have trained dozens of participants and staff of treatment courts all over there's places I've never heard of, like Pipestone, Minnesota. They have a drug court in Pipestone, Minnesota. I didn't even know Pipestone, Minnesota existed. I've been to some really unique parts of our state because of this work, which is really cool. So what is So next we're going to talk about like what is Narcan and Naloxone. Narcan and Naloxone, first of all, they're basically the same thing. So and you can maybe see it, but so Naloxone is a generic term, and it usually comes in a vial or maybe in an auto injector. Narcan is a brand name. So one company had patent or trademarked the name Narcan, and it comes in a nasal version. Really, they're almost identical medications. They do exactly the same thing. It's just how they're administered to the body. So we're going to talk about how it works and administered, how to recognize the signs, when to give naloxone to someone, and again, this is not a CPR class. So naloxone is a medication available in all ambulances. All hospitals and most ambulances, actually probably all ambulances today. 2016, we were able to secure $290,000 from the state legislation to designate to all of our ambulatory services to make sure that ambulances carried it. It does act in the brain to immediately reverse the effects of the opioid the person has taken, but it only stays in the body about 45 minutes. It is a very fast acting medication. So why do people die? Too much heroin or opioids cause them to become sleepy. The sleepier they become, the breathing becomes slow, more shallow. This leads to low oxygen levels, causes damage to the heart and the brain. And the end result is the heart slows down and stops. So this is called the decline of lifeline. So that red line is what I call the death line, I guess some people have called it, just the decline of life. So if a person gets into that cardiac arrest zone or below that blue line, black line, into that blue zone, they have less than a 10% chance of surviving the overdose. So our objective is to keep them above that black line and out of that blue zone. So somewhere along the line, we need to intervene. And we do that with naloxone and rescue breathing, because then we can divert that line up and away from the cardiac arrest zone to save their life. So naloxone is I call it a miracle medication, and we have a few others in this world. So EpiPens, inhalers, insulin, those are medications that can save someone's life in a medical crisis, right? An emergency. Well, naloxone is in that same category, because when a person's suffering from an overdose, they're in a life-threatening situation. So when naloxone enters the body, so your body has receptors in it, your brain does it specifically. So any medication or drug you put in your body has what's called a receptor to accept that medication or drug. So we have opioid receptors that naturally occur in our brain and our bodies. So once the opioid enters the body, it actually is strong enough to knock the naloxone is strong enough to knock the opioid off the receptor and then block it. That's pretty cool. But then it prevents the rest of those opioids that are floating around in the brain near those receptors from going into the receptors. The problem we do have today is we have really strong opioids out there, unfortunately. Fentanyls, carfentanyl, sufentanyls, there's a whole bunch of them. And very rarely do we see 1 or 2 doses reversing an overdose anymore. More commonly, because of the high potent opioids, it's 3 to 5 doses is common. All of our kits do carry 3 doses in them, only because the Steve Rimmer Hope Network made that decision. I think to my knowledge, they're the only ones that do it. I've heard now others are starting to because of the fentanyl, but they were the first ones to do that in 2016 when the fentanyl started really showing up. We added an extra dose to all of our kits. That's really, yes, it's just going to be necessary, especially with the medication or the drugs that are out there today. So what will naloxone work for? So heroin, morphine, hydromorphone, oxycodone, hydrocodone, fentanyl, carfentanil, buprenorphine, which is Suboxone, codeine, and methadone. Those are all opioids. So that picture that you see on the right is what the CDC had determined to be a lethal dose of each of those drugs. Heroin is about 10 times stronger than morphine, so it takes quite a bit of powder to actually kill a person. And I just want to point out those vials are about the size of my naloxone vial. Fentanyl, so we have a wide range of fentanyls in the world that range anywhere from 100 to 1,000 times stronger. In fact, a year ago, the FDA approved a new fentanyl that's 1,000 times stronger than morphine, and it's only going to be used in surgical procedures and blah, blah. Low risk of diversion. We've heard this before, right? If you don't know, and I mean, I'm not here to bash anyone, but the FDA gets 50% of its funding from the pharmaceutical industry, so they benefit every time a new drug is approved. It's unfortunate. So anyways, fentanyl, again, 10 or 100 to 1,000 times stronger than morphine. The one on the end called carfentanil is the one we're scared to death of, and we every right should be. So carfentanil is 10,000 times stronger than morphine. Carfentanil is only used for one purpose in our world. So that grain of salt, or 1 or 2 grains of salt that you see in the bottom of that vial, that is enough carfentanil to tranquilize a 13,000-pound elephant. So that little bit will put them to sleep, put an elephant to sleep for a few hours so they can do surgery on it, so they can transport it, they can move it, whatever they need to do. That same amount of carfentanil will probably kill the 4 of us in this room and how many are on the phone today. That's how dangerous that stuff is. Every year in Minnesota, we see between 10 and 13 deaths that are related to carfentanil. And then people say, where does it come from? And so the only people that have access to that medication are zoos, because they're the only ones that use that powerful for their large animal tranquilizers. So it's being diverted out of those zoos in the United States, is what we think. There's other things, though. China just recently now cracked down on the fentanyl and carfentanil. The only place you can get carfentanil is China. It's not made anywhere else. We don't have the recipe. We don't have the right ingredients, thank God, to make it here. Not yet. Hopefully we never do. And it's really scary. I just think even along the lines of fentanyl, as I work as an alcohol and drug counselor, it scares me when I talk to patients and I hear them say, when I ask them what your drug of choice is, and they actually tell me it's fentanyl. And I'm like, well, I just don't get it. I got it's so dangerous. Yep. So I can get a little tiny bit of fentanyl that'll last me 10 times longer than the heroin will. And they're willing to take that risk. And it's just scary. So we're in some scary times. One thing, I don't want to go too long here. I work with SAMHSA a lot. SAMHSA's Abuse Mental Health Service Administration. And Dr. Volko says we're kind of in the 4th phase of this opioid epidemic. The first phase was prescription pills. So the pharmaceutical industry dumped millions of pills into our communities, which got people hooked, right? The second phase is people started to be cut off from those pills. Then people turned to street drugs like heroin, which was cheaper, easier to get. So the Mexican cartels would be dumping massive amounts of heroin into our communities. Then we entered this, what we call synthetic phase, the 3rd phase, where we started seeing China shipping over this fentanyl from overseas. And now we're entering what Dr. Volko calls the 4th phase, where we're seeing the fentanyls in all of our other drugs. So she calls it the stimulant phase. So even our stimulant drugs are killing people because of the fentanyl in it. So let's hope and pray this is the last phase of this epidemic and we can get past this. I know we're a smart country and we have the resources. We can do it. I just think we need to be devoting a lot more energy to it. I mean, just look at example, just recently, the coronavirus. I mean, this is scary, right? If you read about it, look how much we've thrown billions of dollars at it already to make sure we don't lose. But why aren't we doing that same aggressive behavior with overdoses? Well, we're addicts and junkies and all those fun things people like to call us, right? So anyways, I'm not here to, it's not all doom and gloom. A lot of us are doing great work to fight this, and it'll continue. We just need the resources. And when I say resources, I mean money. It's going to take a lot of money to fix this epidemic. So naloxone won't work for other drugs such as alcohol or any benzos, so Valium, Xanax, Klonopin, antidepressants, really no mental health medications. The beautiful thing about naloxone is it's it doesn't hurt anyone, so less than 0.01% of people have ever shown a side effect or allergic reaction. So I have no idea when someone overdoses what medications or drugs they've taken. I don't know. So the beauty is if you suspect an overdose, you should just always give the naloxone because it's not going to hurt anyone. Really, the only side effect of it is life. So types of administration. So IM is the most common. That means intramuscular. It's given in IVs in hospital. They still use. They've used it. Since I think it was discovered in '64, FDA approved in '71 or '72. So it's been around for a long time. Just in the last decade, has it been available in the communities? We give out the intramuscular kits normally only because of cost. Those are a few bucks to put together. The nasals in the hundreds, and the other one, the auto injectors, in the thousands. So some side effects a person will have, they'll likely develop are some vomiting, sweating, shortness of breath. These are essentially overdose symptoms, and they should be expected. I mean, if a person's a heavy user, not even a heavy user, an occasional frequent user of opioids, and you will cut that supply off from their brain, they're going to feel some side effects. However, I always like to point out, like, the side effects outweigh the advantages. So I always say I'd rather have my person alive in a withdrawal than dead. So if I put my friend into a withdrawal situation, I'm okay with that because they're still alive at least. So again, if they're only sleeping, it won't harm them. If they're under the influence of other substances, it doesn't matter. The naloxone, again, when we're talking about multiple drugs in a person's system, so let's say they're a cocaine user and there's fentanyl in their cocaine and they overdose. The overdose is caused because of the fentanyl, most likely not because of the cocaine. So the naloxone will still work to reverse the overdose. So it's okay to use. And again, it won't hurt them. So what to look for: slower, shallow breathing, gasping for air when sleeping, blue or palish skin, slow heartbeat or low blood pressure. And they won't wake to a sternal rub. So sternal rub is really easy. You take your knuckles and you rub someone's sternal right here and rub it good and hard, feel the bones. And if they're only sleeping, that will most likely wake them up. If you watch any of those cop shows today, Live PD or any of those shows, you'll see them do it all the time. It's a real common thing, and it's an easy way to get someone to respond is by rubbing their sternal. So again, look for the signs. They're sleepy, can't be woken up, breathing is slow and absent. Pupils are really important. So as my friends tell me, I've developed a bad habit in the last part of my life here. I stare people in the eyes a lot when I talk to them. I don't really do it. I don't know I'm doing it. I just do it unintentionally. But because when I work with people in treatment, patients, I can look in their eyes, right? And if their pupils are dilated like owls, they're using a stimulant. Really easy to tell. But if their pupils are pinpoint or small, they're using an opioid. So the pupils are a really quick indicator to tell how someone is responding. So once you've identified that they're overdosed, the first thing you should be doing is calling 911. Again, Steve's Law protects you, and time is of the essence here. I mean, if you're in the metro area, so I live in Golden Valley, and if I dial 911, in under 6 minutes, there is a first responder to my house with Narcan. That's a really great response time. All the metro, like the 5-county metro area, maybe even 7-county, we're under 11 minutes now. So we have a really great response time. But if you get outside those metro areas, the times drop very quickly. I was in a little town a year and a half ago, Madison, Minnesota. So Lockheed Parlay Valley High School. I might have said that right. Yep. So I was there, and that's the one. And they're not really in the town though. Like, they're outside the town. And I said to one of the teachers was in my class, and I said, "How long does it take when you dial 911 for a first responder show up?" And she goes, "Oh, a good 20 to 30 minutes." I'm like, so that's a death sentence. If you don't have Narcan at the school, someone's going to die. So again, response times are very important. So inside of every kit, in case you don't know, you get a kit given to someone or someone gives you one or you give one away, it's okay. Inside of every kit, there's an instruction card that'll walk you through the steps on how to save someone's life. If you follow that instruction card, you're guaranteed it'll work. It's guaranteed it'll work. So it's important. So first thing we'll do, attempt to wake the person. They say yelling or shaking. I don't, maybe grab their shoulders and take the sternal rub's the best. Call 911, get out your SCOOP kit. So SCOOP is an acronym, and I can never remember what it stands for. We have too many acronyms in this world. Everything is an acronym. We also provide you with some other safety equipment inside of the kit. There is exam gloves for you to bring, alcohol wipes to clean the area where you may inject them. There's a breathing mask, which is a one-way CPR mask. So we really do want you to be as safe as possible while you're saving someone else's life. And so we call that like best practices is what we try to talk about. So we're gonna first give them 2 rescue breaths. So flat on their back, tilt the head, support the neck, tilt the chin, breathe into the mouth. We really want to see the chest rising and falling, not the stomach. If the stomach is, you're just probably blowing air down their feeding tube and it's not getting into the lungs where it needs to be. Usually a quick fix is just to tilt the chin a little bit more. Now I'm old enough to remember my first CPR training, and they told us this move may look familiar to some people. So that's called check the mouth and scoop the mouth out. So we don't do that anymore because we found, especially with overdoses, there's a much higher seizure rate. And if someone has a seizure while your finger is in their mouth, you're right, you will not get your finger back. It's going to be their finger. So please don't stick your fingers in anyone's mouth. But try the rescue breathing is pretty important. So start with 2 rescue breaths. I'm going to do a quick demo for this part. So usually,
Rick just said scoop is skills and knowledge on overdose prevention.
what do you say?
He said skills and knowledge on overdose prevention.
Scoop is.
Oh, scoop. Oh, okay, good. Thank you, Rick. So Rick is he has a photographic memory. Everything Rick sees or hears, he remembers. Thanks, Rick. I love the guy. He's amazing. So I'm going to do a quick demonstration. This slide walks through the process. So each syringe is individually packed, and these are 22 gauge 1.5 inch syringes. So these aren't tiny little toys. They're pretty significant. So these do have what called removable tops. So I would say make sure that it's on tight. So righty tighty, lefty loosey. So a twist to the right, you can feel it gets on tight. We don't want it to leak air. We don't want it to fall off in the process, things like that. So then we're going to pull the cap off. And I want people to be careful. So this is a dangerous instrument. Now I have a paramedic friend that showed me how to recap this syringe when I'm done. I'm going to show you that. Again, though, if you have different advanced medical training and it's something other than that, use your medical training. This is just the way a paramedic friend of mine showed me. Each naloxone vial has an orange sterile cap on it. That sterile cap pops off really easy with your thumb and exposes the rubber stopper. So the first thing we're going to do, so the way I was taught to load this syringe, so air will be our friend in this case. I know some people that are familiar with syringes, air is a problem. So Hollywood has done a great job of scaring us to believe that if you inject someone with air, you'll kill them, right? So there's a little truth to that. The problem is it would take about 10 cc's of air into a vein to kill someone. So we're operating with a 3 cc syringe, so not enough air to kill anyone. And we're really hoping to go into a big muscle. We're not going to hit a vein most likely anyways. So I always pull the plunger back to load my syringe with air because the air is going to be our friend to help load the medication. You take the syringe, punch it down through the center of that rubber stopper, put it into a position like you're going to administer between the first and second finger, push the plunger down and hold it down. So the air pressure right now has pressurized this vial and it's pushing back against my thumb. Turn it upside down, put the top tip of the syringe in the bottom of the fluid and just let go of your thumb. So you can see how easily that loaded the medication. Like I didn't have to do anything. The air did all the work for me. Now we're going to go into, there's 2 places that are best to inject, which I don't know. Oh, good. I do have the slide on here. So again, if you can expose the syringe is 1.5 inches long. So if you can expose and get down to skin, use an alcohol wipe to clean the area first. That's best practices. I don't think anyone has ever used our alcohol wipes, but our medical director insists that they stay in there, so fine. It will go through a couple layers of clothing. Now, if they have a big winter coat on or those big cargo pants, Carhartt pants, like you might probably want to be careful because you don't want to go through too many layers, but we do want to get into the muscle. So the 2 best places are the outer shoulder or outer thigh. And this is a time when I tell people, now if you're scared of syringes, I get that. And I understand that. It can be very stressful. I want you to just take a couple deep breaths and think about it. And I really want you to poke them all the way in. Like people say, well, if I go into their arm and what if I hit their bone? And I said, great, you're in far enough. So honestly, you want to go in all the way. And then we're going to give them that whole dose, 1 shot, 1 dose, and we're done. Now, when you pull that syringe out, we do have a much more dangerous tool, I would say, because now there's most likely some blood on it. We don't know what the individual had, and we don't want to hurt ourselves. So I was shown this way to recap a syringe. Again, if you have medical training, use different. I always put my opposite hand behind my back, but I slide the syringe into the cap, and then I lift it up. Then I take my hand and I click it back on. So now I've safely recapped that syringe and I can set it off to the side. I'm not going to worry about someone getting hurt. There's one other area of the body that is, so sometimes people use on toilets and they fall over off the toilet and there's only one area that's exposed. So the butt, right? So it's not a highly recommended area. So under your waist belt and above your pocket, there's a muscle on each side of your buttocks so no pun intended, but the butt will work in a pinch. Because sometimes that's the only area we have to. We have to be careful in the buttocks. If we get too low, there are some nerves that run through our butts. And if you hit one of those nerves, you're going to hurt the person. They're not going to feel anything until they wake up, and then they're going to wake up with a big pain in there. You know what? It's okay. Again, we have a Good Samaritan law in the state that protects you from being sued or because you're trying to save someone's life. So really, that's a last resort, but it is an acceptable place to inject someone. So if there's no improvement after 2 minutes, it's simply we just start over. So this is where I talk about, so Chuck Woolery, for those that maybe know who he is, so he ran a show called The Love Connection, and Chuck would always say, we'll be back in 2 and 2. That was his famous line. So naloxone administration is very similar to that. So we're going to give 2 rescue breaths, we're going to give a dose of naloxone, and we're going to wait 2 minutes. During that 2 minutes, if the person isn't breathing or breathing not very well, we do want to provide them a breath every 5 seconds. After that 2 minutes, if nothing's changed, we just start over. We give them another 2 rescue breaths, load up another dose of naloxone, give it to them, and then wait 2 more minutes. And we keep doing that cycle. No matter which version I talk about or show today, that cycle is the same. 2 rescue breaths, dose of naloxone, 2 minutes. And we do that until we run out of naloxone, until the person responds, or until help arrives. We use all of our tools. The patient wakes up, don't interfere with the action, but stay with them until help arrives. They really should go get checked out. The minimum recommendation from our medical director is 2 hours that they should be medically supervised or supervised not to. So unfortunately, those of us with a disease of addiction, we don't make the best choices when we're under the influence. And especially after getting naloxone, they're not going to feel real good. What are they going to want to do? They're going to want to get high. So that's a death sentence. The naloxone is blocking the receptors, and they're going to pump a bunch more opioids into their body. Then the naloxone wears off and they die. So we can't let them use again under no circumstances. The other ones out there you'll see on the market, one's called the auto injector. We don't see this one a whole lot anymore, only because one reason is why, because the cost. So when they first came out, it retailed for about $500. Several years ago, when the naloxone demand went up, so did the price. Now they retail for $4,800. They said they were going to make a generic version, and it would only retail for $189. I've never seen one yet on the market, so I don't know whatever happened to that. If you want to watch a very interesting 60-minute special on this company, about a year ago, they did a special on them, and they made like $142 million billing Medicare and Medicaid, and they claim they still didn't make a profit on the product. So it's a little disturbing. Again, I'm not trying to be anti-pharma, but I think we all know that they're definitely the root cause of a lot of our issues. You can't not turn on the news today and see the problem with prescription drug prices, right? It's on every day. We talk about how high our prescription drug prices are. This is one example of thousands of why there's a problem with our prescription drug prices. So the atomizer is one. It's it is a cheaper nasal version. You really can't. This is harder to find. Some of our first responders still carry it because it is less expensive nasal version, but it does require some assembly, and it gets to be more complicated for the lay or the normal person to use. The nose is the perfect place to absorb medication. The nasal mucosa gets more blood flow than any other part of the body, so it is a good place for medication to go. So again, make sure you call 911 right away. Here's the newest one, the nasal spray called Narcan. They come in single dose packs. Basically, you peel the foil back off. There is an instruction card folded up if you need it. But after the 2 rescue breaths, you shove up their nose. This is a demo one, so I'm not going to, but you put it up their nose and you just push the plunger and you're done. Wait 2 minutes, breathe for them if necessary. If nothing improves, grab a new dose, open it up. We do recommend alternating nostrils every dose for the nasal, only because sometimes people do use drugs up their nose, right? Even if they do that, though, it'll still work. It doesn't matter because it absorbs the mucosa and there's open capillaries very close to the surface. So it's hard to know what emotions or behaviors a person will have upon waking up. They've been with the oxygen for a while. They may be confused, agitated. They may stay sedated. Again, call 911. Some people have emotions such as anger, embarrassment, frustration, or sadness. None of these possibilities should delay you in giving naloxone. I always think it's funny, and again, I'm not here to make fun of the police, but it's always the police that I hear the most say that a person wanted to fight them after overdose. And I said, if I woke up and I saw 3 cops standing over me, I'd probably want to fight too. Those of us that use drugs don't interact well with the law enforcement. It's just a fact. So most cases, I don't hear people getting violent. Again, so it is important in Minnesota. We have a thing called winter. You can't inject someone with an ice cube. So if it's frozen in your car, it's not going to work. We do now know, though, there's been a lot of great studies done on naloxone that temperature really doesn't play a factor, and it's how effective it is, but it does play a factor if it's frozen. The UV light can be dangerous for it, so it should be kept in a UV protected bag. Naloxone does have a 2-year FDA required expiration. Again, we've done studies on it to find out that it's good at minimum 66 to 97 months is one study, so that's 5+ years. I understand we work in facilities that have licenses, and because of that license, sometimes we have to abide by those 2-year expirations. I get that. So if you have expired stuff, really it's Minnesota Department of Health license says you can't keep expired medications in your facility. That's just the rule. It's unfortunate, even with naloxone, but it is the way it goes. If you have an expired kit, the Steve Irwin Hope Network does their best to take that back and exchange for a new one. You cannot harm someone by giving them naloxone. In many cases, just save their life. The number one question I get asked from the media, family members, and loved ones is, do you think giving Narcan to people just enables them to use? And I used to get really mad at this question because I'm in recovery and I'm a counselor. And but I decided, like, people weren't changing their mind. It was just me getting upset, so I changed my approach. So now I just say, nope, the only thing Narcan enables is breathing, and if it was your loved one, what would you do? So people always ask me after training, what should I do? So advocate for yourself, for your loved ones. We're only 1 of 2 countries in the world that have TV commercials for drugs, New Zealand, the United States. So we should know what we're putting into our bodies. So become educated. Talk to your local first responders. If you live in a community that doesn't carry it, they don't carry it. Why? They should. I would love to help. I could help them do it. I've helped hundreds of organizations carry Narcan over the 6 years. Local schools, church groups, really anyone. I mean, again, I've trained as few as 1 person in the lobby of a bar once to as many as 175 at a conference. Pick 3 people to talk to today. Tell them about naloxone. Let's make this more normal. Participate in advocacy efforts. Again, talk to your local elected officials. You can go to get naloxone at any pharmacy. Talk to your doctor. They can prescribe it to you. If you work in an agency and they don't carry it, maybe you could help them get it and work on that. That's the end of my presentation. So any questions? Do we have questions or do questions?
Yeah, we can do a
If there
couple
are.
quick questions. Whoops. I've got to do a little unsharing and that kind of
Gotcha,
thing.
yeah.
There we go. So what I want to just do, because we only have a few minutes left and we'll take a couple questions. We are going to, is there anything in the chat? We're seeing lots of thank yous and, but not a lot of questions. Let me just do a little bit of housekeeping. There's a couple of people that we don't have your emails. The way we do our evaluation and our continuing education is via email. So if you are someone who hasn't signed on before, will you please type your name and email into the chat, and we'll make sure, and if you're in the room with a big group of people, type all the names and all the emails, and we can get the evaluation, and at the very end of the evaluation is a checkbox. Yes, I'd like the continuing education certificate, and we'll get that back out to you. I know that's important to a lot of people.
They can email. I see a question, how do we get kits? So I can connect you to the Steve Irwin Hope Network, and they can probably get you some kits. I don't have a big supply of them right now. My email address is boldnorthrecovery@gmail.com. So really easy. boldnorthrecovery, all one word, @gmail.com. And you can email me, and I will connect you to the Steve Irwin Hope Network, and they can get you some kits.
We'll also make sure that everyone gets a PDF of the slides from today, but we have to have your email to do that. So be sure to get that to us in the chat if we don't already have it. And then you'll have the slides, and your contact information was also at the end of the slides.
Yeah, at the end of the slide is the Steve Irwin Hope Network's email and their phone number and everything, but I don't think I put my contact in there, but.
Well, we'll put it in too, in your email. So I have time for maybe 1 or 2 questions. If you want to just unmute yourself, you could ask, or you can type.
All right.
All right. So our next ECHO session will be on the 5th of March, and we're going to have representatives from the Twin Cities Recovery Gym and Wellness Center, which is kind of cool. I was really excited to find that something like this exists. It's a place to take good care of your body and while you're living life in recovery, and they're going to tell us more about the facility and also why it's important. Let's see. I think that's it for right now. I've already talked about evaluations and emails. Please invite your colleagues to join us. We love this crowd. We're so excited that you're all here. We're doing this every 1st and 4th Thursday. If anyone else in the room is a peer recovery specialist, coach, mental health peer worker, we also have a peer support echo, and that one takes place on the second and fourth Thursday over lunch. And you are certainly welcome to join that one. We alternate between kind of best practice topics and then case conversations where we provide input to each other and support each other in that really important work. It's a way to build your professional network. So thanks so much for being with us. Stay warm, and hopefully we'll see you next time. Okay.